Respected Clay sir, again I would like to thank him for making me a part of this nice program. So my topic today is arrhythmogenic coronary sinus. So this is the outline of my presentation. Introduction, embryology, anatomy, mechanism, CS as a source of atrial arrhythmia, role of CS in AVNRT, role of CS in AVRT, role of CS in ventricular arrhythmias, and concluding slide. So for an electrophysiologist, coronary sinus is a very important structure as it is an electrophysiologically active. And most of the time, if we are not able to cannulate the coronary sinus, we cannot go ahead. So it's as important as we do the procedure. So it's a part of the cardiac venous apparatus that connects the left atrium and to the right atrium. There's a myocardial sleeve around the coronary sinus, which is composed of bands of muscles from LA and RA wall. CS pouch is a congenital outpouching with distinct neck extends behind the left ventricle. Myocardial fibers of coronary sinus establish connection between the coronary sinus cord and the ventricle. So coming to the embryology, as you all know, in the third week, heart forms like a single tube and it is made up of differentiates into primordial atrium and sinus venosus. And in the fourth week, sinus venosus further differentiates into left horn and the right horn. Right horn forms the SVC and IVC by differentiating, and the coronary sinus is formed by the left horn of the sinus venosus by further differentiation. So coming to the anatomy of the coronary sinus, you can see here the right side is the fluoroscopic view in the LAO. This is the coronary sinus. This is the coronary sinus os. So there is coronary sinus musculature which extends from the os to the ligament of Marshall up to here. So this is the musculature which you can see here, and this is the ligament of Marshall, and all the musculature, it is arising from the os to the oblique vein of Marshall, and it is there is a wall in the beginning of the os of the coronary sinus which is called the Thebesian wall, and it engulfs in the superior and the posterior part. So sometimes all of the coronary sinus will be occluded, there may be fenestrations, but most of the time there is the wall is in the superior and the posterior part of the os of the coronary sinus. So what is the mechanism of arrhythmogenesis in coronary sinus? There is spontaneous depolarization and slow conduction in smooth muscle of coronary sinus. So spontaneous depolarization and abnormal atomaticity is the one of the cause of atrial fibrillation, and then vein of Marshall, which is in the midst of the coronary sinus, has a rich innervation of autonomic nervous system. It has myocardial extensions and node-like remnants inside the vein. So these all things make it more arrhythmogenic, and it is one of the cause of attributed as one of the cause of atrial fibrillation. Coronary sinus connections between the both atria, if it is there, so there can be re-entrant tachycardia, which I will be showing in the case series, which I'll in the coming slides. And as we all know, there could be epicardial axillary pathways. These are nothing but myocardial extension, and they form the epicardial axillary pathways. So coming to the atrial arrhythmias in coronary sinus. So as I was telling, the ligament of Marshall in atrial fibrillation, it is seen in the mid part of the coronary sinus. So this is an elegant paper by Tai et al. Published in 2000 in PACE. If you can see here, there are three potentials are there in this channel. So during sinus rhythm, this is the ventricle. This is the you can see the left atrial potential, and then this is the atrial potential, and during AF, this is the vein of Marshall precedes the left atrial potential, and this is a pulmonary vein potential. So there are three potentials, and this being the trigger for the atrial fibrillation. So whenever there is atrial fibrillation induced in this study, they have seen this ligament of Marshall is preceding. Whenever the APC, which triggers the atrial fibrillation, this is the vein of Marshall potential leading to the atrial fibrillation. So when in this paper, when this was targeted, it led to the suppression of atrial fibrillation. So as we all know, myocardial sleeves are in the pulmonary veins are the trigger for paroxysmal AF. So these are the non-pulmonary venous triggers, and ligament of Marshall, there's a vein of Marshall, which is a remnant from the CS to the pulmonary vein. It is a connection, and it is more seen, it is nothing but a remnant of LSVC. So it has all the potentials of arrhythmogenesis. It has high innervation of autonomic nervous system that leads to the this atrial fibrillation. So So this was a study done, published. It was a paper published. It has shown that this vein of Marshall can cause even atrial flutter, perimetral atrial flutter. So if you can see here the 3D imaging. So this is the Hurley meets the lead. So this is the activation pattern, counterclockwise loop. There is a flutter which is counterclockwise loop, and this is the area where the Hurley meets the lead, suggesting of a re-entry. And you can see the vein of Marshall potential here is outside the window, which is suggests re-entry, and it was not accessible by endocardial ablation because vein of Marshall being a epicardial structure. So what it has been done, the coronary sinus was cannulated and it was wired. This is the balloon, over the wire balloon, and the alcohol was given, and that led to the suppression of the flutter. So during alcohol ablation, the atrial flutter terminated to sinus rhythm. So this being an epicardial structure, we may not get success when we do endocardial ablation, when we do pulmonary vein isolation, when we do endocardial mitral line or mitral flutter. So in such cases, you see this potential and then think the coronary sinus may be the trigger, the vein of Marshall may be there, and then you have to cannulate the vein of Marshall, do alcohol ablation to get rid of the flutter. So coming to atrial fibrillation, this was a paper published in late 2001 by late Dr. Mohan Nair sir, and was published in Circulation. So in this, 17 patients were studied of rheumatic heart disease. The atrial flutter and fibrillation was induced in the lab, and once it was induced and then the study was done, it was seen that coronary sinus was the initiator for the atrial fibrillation. So you can see here, this was the coronary sinus CS910, which represents the coronary sinus os, is the initiator for this atrial fibrillation. So by ablating at this part, the atrial fibrillation terminated. And around 52 weeks, after 52 weeks follow, it was seen that 10 out of the 13 patients were in sinus rhythm. And the people who had again reinduction of the atrial fibrillation on table, they were in atrial fibrillation. So on table who got success and there was no AF induced, these subset of the patients, they fared well, and this shows that even though in rheumatic heart disease, this subset of the patients had a trigger from the coronary sinus. And in the another fact in this paper was that pulmonary vein trigger was not seen. What they had attributed was, as in rheumatic heart disease, there is no muscular sleeves. It is replaced by fibrosis, inflammation and fibrosis. So the pulmonary vein sleeve could not be a trigger. Second thing, these subset of the patients were on amiodarone. So that is the reason pulmonary vein trigger could have been suppressed. So this was the reason given to that the pulmonary vein trigger was not seen in the rheumatic heart disease in this paper. So then in 2014, there was a canine models were studied, and there is isolation of the canine model was done, and they were seen that these canine patients, they were induced atrial fibrillation, unstable atrial fibrillation because of re-entry, and when it was completely isolated, these subset of the patients, it prevented recurrence of atrial fibrillation. So this was a paper done in 2014. This is the latest paper which compared in humans around 100 patients. It was divided in two groups where coronary sinus isolation was done, in another group non-coronary isolation, which means non-coronary isolation means these patients underwent pulmonary vein isolation and roof line. So this is a pulmonary vein isolation and this roof line isolation was done. And they compared with pulmonary vein isolation, roof line and coronary sinus isolation was done. So in this, what they saw that by doing a coronary sinus isolation, the arrhythmia-free period or the long-term recurrence, it didn't have much bearing. So they said you have to subset for coronary sinus isolation when all options are of the non-pulmonary venous triggers are ruled out, and if you have a pulmonary CS as a firing, then only you go for a coronary sinus isolation. So much study is needed, but this is the latest study in which it has shown that coronary sinus isolation may not be useful for all the patients. So coming to the clinical cases, a 53-year-old male, palpitations with pre-syncope off and on since 1 year, and he had increase in symptoms in last 2 months. ECG showed pre-excitation, negative delta wave in 3 and AVF, and echo showed normal LV function, angiogram, mild double vessel disease. So this is the baseline ECG. Lead 2, there was no negative delta wave. Delta wave was negative in 3 and AVF. and pre-excitation was there. By this ECG, we think of a right posterior axillary pathway. So this is the baseline ECG. There was no documented tachycardia in this patient. This is the baseline ECG. As you can see, HV was less and because of pre-excitation. And easily just RA-S1 atrial stimulation induced atrial fibrillation. And he said this was the clinical tachycardia. And then we cardioverted, and this is the intracardiac ECG showing the atrial fibrillation. And once we cardioverted, he was in sinus rhythm. And this is the 3D mapping. This is a coronary sinus. This is the coronary sinus pouch. He had a pouch, and then ablation in this pouch. This is the coronary sinus pouch, and ablation. This is ablation catheter, flexibility catheter, irrigated catheter at 25 watts, 17 ml per minute. And the ablation was given for 130 seconds, and there was no pre-excitation. And post RFA, atrial extra stimuli and VES both were given under isoproterenol, and there was no AF induced, and even adenosine 18 milligram was given, and there was no reconnection of the pathway. So this is the post RFA ECG. There is no pre-excitation, and this patient had a atrial fibrillation because of coronary sinus pouch. Another case, a 38-year-old lady presented with palpitations off and on in spite of taking antiarrhythmics. This is the clinical SVT ECG. As you can see here, it's a long RP tachycardia, and this is the intracardiac ECG showing the tachycardia. So you can see it's a regular tachycardia, and then earliest activation being in the C7-8, and ventricular overdrive pacing was done, and it was a VAAV response, and antegrade and retrograde was by a fast AV node, and ventricular overdrive pacing showed the VAAV response suggestive of atrial tachycardia. So we took her up for the electrophysiology study and radiofrequency ablation. This is a fluoroscopy. This is the ablation catheter within the CS near the C7-8. So during ablation, this was the signals 30 milliseconds earlier to the P wave. So during the ablation, the tachycardia terminated and patient was in sinus rhythm. So this is the 3D mapping. This is the SVC end, IVC end. This is the coronary sinus. You can see earliest activation in the CS, and the power was 25 watts, and it was earliest from the P wave origin was 30 milliseconds, and during ablation, patient terminated, the tachycardia terminated, and patient was in sinus rhythm. So it was a coronary sinus atrial tachycardia. So another patient, 45 years old female, presented with palpitations off and on with pre-syncope since 2 years. ECG showed pre-excitation, negative delta wave in 2, 3, AVF, V1, and echo normal, angiography normal. So when you see a negative delta wave in 2, 3 and AVF, as per Arrhymogenic algorithm, you must think of an epicardial axillary pathway. So with a pouch. So this is the baseline parameters. In fact, she had intermittent pre-excitation. You can see here HV was normal on table. So when we induced, she had easily inducible atrial tachycardia. And then she had terminated into it. The AF was also induced. So there was AT and AF going on, and there was a spontaneous remission to sinus rhythm. Then this was the intracardiac tracing during atrial fibrillation, as you can see here. So patient had a pouch, and this is the ablation catheter into the pouch, and within 60 seconds the atrial tachycardia terminated, and she was in sinus rhythm. And this is a pouch, you can see. So post ablation, the normal sinus rhythm, there was no pre-excitation. Adenosine 18 milligram was given. There was no reconnection of the pathway, and aggressive AES and VES was done under injection isoproterenol 4 microgram per minute, and there was no AT or AF induced. This is a post-RFA ECG, and this is a case of CS pouch with atrial fibrillation and atrial tachycardia. Now coming to the most common arrhythmia, that's AV nodal re-entry tachycardia. So what is the role of coronary sinus? It was seen that coronary sinus os was dilated in patients with AV and RT. So what it did was, it led to separation of atrial inputs into the AV node, and that led to the increased isotropic conduction. Windsock morphology of CS os also led to the different muscular arrangement of the CS. So that also further enhanced the substrate for re-entry. and left variant of slow fast AVNRT, CS-OS ablation was useful, and also in a typical AVNRT, CS-OS ablation is useful. This is a paper published in Jais et al. In Jais by Mary et al. So it was seen that the coronary sinus os was very much dilated in AVNRT and more so in typical AVNRT than in atypical AVNRT. Whereas AVRT patients had a tubular coronary sinus. So just by taking a coronary sinus injection, you can have an idea of what type of SVT you are going to encounter. If the coronary sinus catheter goes easily, and it means that this patient is likely to have AVNRT because this patient has AVNRT patient has a dilated ostium of the coronary sinus around more than 15 mm. That was studied in this patient. So in the patient, the clinical case, 70 years old male, presented palpitations off and on since 6 months. He was symptomatic in spite of taking antiarrhythmics. As you can see here, this was a RAS1 S1 easily induced tachycardia, and this was a concentric atrial activation was seen. Its refractory VPC could not reset the tachycardia, and VA during SVT was 20 milliseconds, and VA during RV pacing at the rate of tachycardia cycle length was 130, and the difference between the two is more than 85 milliseconds, suggestive of a typical AVNRT. So this patient had a dilated coronary sinus os, you can see here, and the ablation at the coronary sinus os terminated the AVNRT, and it was made uninducible, and patient was done in basically whenever AVNRT is there, you terminate it by overdrive pacing, and then based on the atrial electrogram, small a and small v at the low Cox triangle, generally we ablate, but in this case, I had ablated at the CS source and we had success. Now coming to axillary pathways, the epicardial axillary pathways, they account for 8% associated in the coronary sinus. 70% of the coronary sinus axillary pathways occur without a diverticulum. And if you can see here, these coronary sinus myocardial port has connections from both atria, right and left, and it is connected to the MCV, and it has an oblique course. So, as previously said, both atrial connections will be there to the atria, and this will be connected to the ventricle and via the epicardial veins. So it has an oblique course. These are the things which you must keep in mind when we do ablation for AVRT, especially pertaining to epicardial axillary pathways. I'll run through some of the clinical cases. A 57 years old male presented palpitations off and on since 4 years. He had history of 2 episodes of syncope 1 month prior to admission. He had symptoms in spite of taking antiarrhythmics. ECG showed pre-excitation, negative delta wave in 2-3 AVF and V1, and echo was normal, angiogram was normal. So this is the baseline ECG. As you can see, there's negative delta wave, 2-3 AVF and negative in V1, suggestive of a epicardial axillary pathway. So this is a baseline parameters. AH is 84 milliseconds, HV is 14 milliseconds. Then easily inducible AVRT, short RP tachycardia. So this is the coronary angiogram showing the CS pouch. You can see the CS pouch here. You can see here also the CS pouch, small CS pouch, the levo face of the coronary angiogram. Then we did 3D mapping. This is the way CS pouch is there, and at the neck of the CS pouch, we could get success. And it took almost 16 minutes to get success. And this is a pre-excitation. This is the signals in the ablation catheter, choose VA signals, and this is likely to be a pathway potential. And after ablation, you can see the patient was in sinus rhythm. So this patient was doing well for 3 months after the procedure. Then he had a pounding sensation and missed beats. ECG showed no evidence of pre-excitation, but atrial premature complexes were present. So this patient underwent Holter monitoring, which showed there was atrial runs, and then the APC burden was 21%. You can see here, this was the AT run and inverted P waves in lead 2-3 AVF, So this patient was symptomatic not for the pre-excitation, it was not the recurrence of the axillary pathway. Though, as we all know, right-sided axillary pathways, there is 15 to 20% recurrence, but he was in sinus rhythm, there was no evidence of pre-excitation, so it was an atrial tachycardia. So if you can see the intracardiac tracing, this is a sinus rhythm, and this is the axillary pathway. So inverted P in lead 2. So it is atrial bigeminy we could see, and this was the signals on the ablation catheter. So this patient, as he was symptomatic, we had taken him up, and then we did the ablation at the same part because we knew he had a CS pouch and ablation has been done here. So during ablation, you can see this was the successful RF point, and then during ablation, all the EPCs were terminated and patient was in sinus rhythm. Now coming to what could be the origin of a APC post-ablation of an axillary pathway. Generally, there have been studies that VPC is seen after axillary pathway ablation in the ventricular insertion site of the axillary pathway because of automaticity, that is immediately after ablation. But in our case, it was not immediately after ablation. It was after 3 months after ablation. So automaticity is less likely to be a cause in this patient. It's more likely to be a micro re-entry. Because as we all know, for re-entry to occur, there must be 3 prerequisites. First thing, there must be 2 substrates with different electrophysiological characteristics. They must be connected to each other, and then there should be unidirectional block. So when all these 3 things are fulfilling, then you will have a re-entry. So in this patient, already we had done ablation, and there will be irregular surface in the coronary sinus pouch in that area. So, and because of that, there could be some micro re-entry, and that led to the atrial tachycardia. So, ablating again in this region made the patient totally, the APCs and the AT disappeared. He was totally asymptomatic. 2 years post-procedure is doing well and is fine. So, it's a recent ECG. There's no APC, no pre-excitation, is doing well. So, it was a coronary sinus pouch which was arrthymogenic in the form of AVRT and then later atrial tachycardia. Another patient, 27 years old male, presented with palpitations with pre-syncope, needing cardioversion at another hospital. ECG showed baseline pre-excitation, negative delta wave in inferior leads and V1, and during symptoms he had a wide QRS tachycardia and echo was normal. This was the baseline ECG, similar to the previous ECG, negative in 2-3 AVF and V1. So, in sudden transition suggestive of a epicardial axillary pathway, and this was a pre-excited AF, as you can see, wide QRS tachycardia, irregular in nature. It is pre-excited AF. One thing, as you all may be aware, one thing what we should not give in this patient is an AV nodal blocking agent. You should not give beta blocker, not give calcium channel blocker, must not give adenosine, you must not give digoxin. Because if you block the AV node, then the increased conduction around the axillary pathway, and the AF with a fast rate will be causing a VF, and it is detrimental. So the treatment for this, if you don't have ablation, the most thing is you should do a cardioversion, be it electrical cardioversion or a pharmacological cardioversion by giving a ibutulite. Nothing else. Even amiodarone should not be given. So this patient had a orthodromic AVRT also. So again cardioversion was done, and he was sent to our center for further management. So the baseline intervents, so HV was decreased, pre-excitation was seen, and this was ablation. During ablation, there's a few signals you can see here. The VA was fused, and this seems to be a pathway signal. And after ablation, the A and V, this is a typical pathway signal, VA fused, ideal point, and this I could get success at the CS pouch, and then post-ablation, patient was in sinus rhythm. So this is the SVC, IVC, this is the right atrium, this is a coronary sinus, and this is a coronary sinus pouch where we could get success. And this is the coronary sinus pouch, and this is ablation within the neck of the coronary sinus pouch where we got success. So post RFU parameters, these are his. HV is normalized, HV is 36 milliseconds, normal HV is 35 to 55, previously it was 14 milliseconds. So when there was pre-excitation, and now patient is in sinus rhythm. So post RFA ECG, there is absence of the pre-excitation, there is a memory T waves seen in lead 3 and lead AVF. and is doing well. More than 2 years post-ablation is spared, is doing well. So this patient had a CS pouch with the AVRT and a pre-excited atrial fibrillation. Another patient, 42 years old male, presented with palpitation pre-syncope off and on since 1 year. ECG showed pre-excitation, negative delta wave with pre-AVF, and positive delta wave in V1. And echo showed normal LV function. He had a PML prolapse and normal coronaries. This was the ECG. So when you see such a ECG, you think of a left-sided axillary pathway and most likely left postseptal. So the same thing, generally, as he was symptomatic, they took him up for EPS RFA. The baseline signals, HV was 10 milliseconds. So this is the orthodromic area easily induced. This is the clinical intracardiac tracing of the SVT. You can see here, the earliest activation was in the CS56. So his refractory VPC could reset the tachycardia. The tachycardia cycle length was 330 milliseconds. Then generally, and he had a easily inducible AF also. So this is the intracardiac tracing showing the atrial fibrillation, chaotic atrial rhythm. Then we cardioverted, and then generally I do all my left side axillary pathway transeptal puncture, and did the transeptal puncture and went into the left atrium, and then did the ablation around here in the CS56 based on the potentials VA fused VA signals. But when I used to ablate with a normal catheter at 60 watts, 60 degrees centigrade, there used to be the local signals used to be separated, but then the pre-excitation used to be present. Then I even exchanged with the flexibility irrigation catheter, but still I was not successful. Then I thought, let us see the coronary angiogram, and then if there is any pouch is there or not, let us see. And when I did the coronary angiogram, there was a pouch in the coronary sinus. So immediately I came out of the left atrium and went into the pouch and did the ablation at the neck of the pouch. The RAO showing this is a pouch, the neck. I did the ablation here and I could get success. And this is the 3D mapping. You see very nicely the coronary sinus pouch. So had I been seeing the ECG and then continuing the left side ablation, then I would not have got success. So this is a successful point. So this is the ablation signals, as you can see, fused AV signals, and this is a pathway potential. And during ablation, it was terminated, and it took a lot of time. What I have observed is that the axillary pathway within the CS pouch, it takes a lot of time for ablation, and you have to do with irrigated ablation catheter. And post RFA tracing, this is the AH and HV, normalization HV. There's no pre-excitation seen. And this is the ECG post RFA, and this was done maybe 2.5 years prior to date. And he recently visited me, and he was in sinus rhythm. Is totally doing well. So it was a case of pre-excited AF and AVRT, but this patient didn't have a negative delta wave in lead 2, and in fact, a positive delta wave in V1, suggestive of a left-sided postseptal axillary pathway, but in fact, he had a CS pouch. So this was the thing which we don't expect generally. Another patient, a 48 years old lady, presented palpitation pre-syncope for 6 months. She had intermittent pre-excitation, and echo was normal, angio was normal. And this is the ECG, baseline ECG. There is no pre-excitation in this patient. Holter was done, which showed pre-excited AF and intermittent runs of AVRT. So she had a AVRT easily inducible. And then when we did the 3D mapping, she had a very big coronary sinus pouch. And then ablation at the coronary sinus pouch neck, it terminated. So it was a very big, I will show the angiogram in the next slide. In this 3D anatomy, this is a coronary sinus pouch, very big pouch. And you can see here, this was the angiogram, this is the still image, this is a very big pouch with a narrow neck. You can see this is such a big pouch she had. So ablating at the neck of the pouch terminated the tachycardia, and after waiting for half an hour, we in our institute, after WPW patients who had a manifest WPW or axillary pathway AVRT, we wait for more than half an hour. At the end of the procedure, we give 18 milligram adenosine, whether to see reconnection of the pathway. We do aggressive atrial extra stimulation and VES under induction isoproterenol. And after half an hour, there's no reconnection, no SVT induced, then only we come out. So the post RFA ECG showing sinus rhythm, and she's doing well. So this was a paper which we presented at World Society of Arrhythmia, Arrthymogenic coronary sinus pouch case series. So the incidence of CS pouch in that 1 year was 4.8%, and all patients had palpitations with pre-syncope, and 3 out of 6 patients with CS pouch didn't have a negative delta wave in lead 1, lead 2. As per Aruda algorithm, if lead 2 negativity, you should think of epicardial axillary pathway with a CS pouch. But these, we had 50% of the patient didn't have a negative delta wave in lead 2. Axillary pathways required longer duration of ablation, and axillary pathways with AF only require short duration of ablation. And reaching in the vicinity of the CS neck may need a support sheath like SLO, and the mean age of presentation of the patients was 44.8 years, and most of them were men. And AF was the most common arrhythmia seen in our series, and by ablating within the CS pouch, AF was non-inducible. We need not do a pulmonary vein isolation or other non-pulmonary vein trigger was not required. So in our subset of the patients, they had 5 patients had atrial fibrillation, and 4 had AVRT, and 2 had atrial tachycardia. So coming to the last part of my talk, that is the ventricular arrhythmias from the coronary sinus. It accounts for 9% of the idiopathic ventricular arrhythmias. In this subset of the patients, they have prepotentials located at the successful areas, and VAs are ventricular arrhythmias are eliminated by delayed effect of the RFA within the AIV. And the ECG classical ECG pattern is RBB pattern, transition zone earlier than lead V1. AVL by AVR ratio is between 1.1 to 1.7, and there's SVS in V5 and V6, and these are likely to be in the great cardiac vein or on the anterior interventricular vein. So this is a paper like LV summit. What do we mean by LV summit? There's the LMCA, there's the LCX, there's the LED, and this area is the LV summit. So this is traversed by the great cardiac vein, that is the extension of the coronary sinus. So it divides into 2 areas, that is the inaccessible area and the accessible area. So inaccessible area is one where, because of the fat and everything, we cannot access if any arrhythmia is coming from here. And these are the accessible area. This accessible area can be accessed via the epicardial venous system, either in the GCV or in the AIV, the anterior vein, which runs parallel to the LAD. So this is the summit area. So the studies which was done by Yamada et al., it has shown that these subset of the patients had palpitations, fatigue, and dizziness, but no syncope. And all the accessible area patients had RBB, and inaccessible area patients had LBB and right inferior axis. And ECG typically by Yamada et al., they show transition earlier than V1, and AVL by AVR ratio is more than 1.1, and they were SVS in V5, V6. Whereas Santangenelli et al., in this study, they showed that there is absence of Q in V1, RS greater than 2 in V1, and Q in AVL by AVR is more than 1.85. There's some contrasting things, but whenever you see such a subset of the patients RBB with inferior axis, think of one end AVL is negative, think that you must map the coronary sinus. So what are the problems arising by doing ablation in the coronary sinus? As you all know, as I already said, the anterior interventricular vein runs parallel to the left anterior descending artery. So in GCV runs parallel to the coronary sinus. So they are very near to the coronary arteries. So if the ablation can cause spasm of the coronary arteries, stenosis of the coronary arteries, or it could be leading to some thrombosis within the coronary sinus. So this was a paper published by us, our group, published in Acta Cardiologica Sinica in 2017. So in a patient who had a ventricular tachycardia, as you can see here, RBB and with inferior axis, and this patient underwent EP study. This is a 3D mapping, and when we took up for the EP study, the coronary sinus branches, they had earlier activation. So this is the ablation catheter into the coronary sinus, and then coronary angiogram was done, and it was slightly more than 5 mm. Then the ablation was done. During the ablation, the VPC terminated, but there was a ST elevation in the leads in V1, V2, V3, and 1 and AVL. So which means that there is LED is being affected. So what we did was, generally when we do ablation in the coronary sinus, the power what we use is 20 watts and 17 ml per minute is the flow rate. What we did is we increased the flow rate to 25 ml per minute. So by that the injury was less and patient's ST elevation disappeared, and he didn't have any pain and he was doing well. So these are the things which we have to keep in mind when we do ablation in the great cardiac vein, the coronary sinus tributaries. So injury to the coronary arteries is a possibility. Whenever this occurs, the flow rate can be adjusted from routine 17 ml per minute, increase the flow rate to 25 ml per minute. That will decrease the injury to the coronary artery. So LV summit is another thing, is that these subset of the patients will be having intramural origin. So simple ablation in the left cusp or in the great cardiac veins will not get success. So we need to have a deeper transmission of the energy, and for deeper transmission of the energy, one methodology is a bipolar ablation. So keeping two catheters, say the left cusp and the coronary sinus, or RVOT and LVOT, or LVOT and the coronary sinus, and the coronary sinus, so the RVOT, various permutation combination can be done. So this was published by Futuyama et al. So, but one thing we have to understand is, with single ablation, the coronary sinus itself can cause spasm of the coronary artery. So if you do a bipolar ablation, there will be entire length, the transmurality of lesion will be there, and there can be damage to the coronary artery. So we should do a coronary angiography to ensure a safe distance from both catheter tips, at least more than 5 mm. The power setting in GCV should start from 10 watts, titrating up to 27 watts, achieve impedance drop of 10%, 8 to 15 ml per minute, temperature less than 39 degrees centigrade, and ablation should be stopped if impedance drop is more than 20%. So these are the things which we have to take care when we are doing ablation within the coronary sinus for the VPCs. So I show a case of a 36 years old female. She is a constant CRPF personnel. She presented with recurrent palpitations with pre-syncope for more than an year. She had a history of radiofrequency ablation 1 year back, and she was on antiarrhythmics. Echo showed bicuspid aortic valve and moderate AR. So this is the ECG. So as you can see here, outflow tract VPCs, and 1 AVL negative, 2-3 AVF is positive, and V1 is LBB type, and small r is there. So this patient, she had a moderate LV dysfunction. She had a high VPC burden of 38.2%. So it was a tachycardiomyopathy. So this is a base, as she had a tachycardiomyopathy, we had taken her up in the lab. So this is a EP study showing the VPCs, ventricular bigeminy, and baseline ECG. And then based on activation mapping, we could see it was near the left coronary cusp, and we tried ablation, but it was not going. And then there was recurrence of PPC. Then we did the MDI, and MDI was more than 0.55. So we thought it's epicardial origin, and then we put the catheter in the coronary sinus. And when we did ablation in the coronary sinus, it used to go back and it used to again come back. Then thought that it could be intramural VPC. Then we did the radiofrequency ablation, bipolar radiofrequency ablation. This is a setup which we use in our lab. So the ablation catheter is a flexibility catheter, and another one is a non-irrigated catheter, and there's inquiry decapolar cable. And there's a returning electrode. Ideally, in the study done by Futuyama et al., what they said is the ablation catheter also should be flexible, irrigated catheter, and the returning catheter also, if it is irrigated catheter, it's better. So we used this setup, and then EGM, when we did this, earliest site was 42 milliseconds, and then this is the thing in the one in the left cusp and one in the coronary sinus. And this we've seen that it's slightly near to the coronary artery, but then I thought it was away from the main part of the OM, so I gave a bipolar ablation for 1 minute, and this was temperature settings. I just started with only 20 watts, so very minimal. And after this was a bipolar left cusp, and this within the CS. This was a bipolar ablation, and then after 1 minute I did coronary angiogram. So there was a lesion in the sun. The VPC was totally abolished, and as there was a spasm and circumflex, and then I thought better it's not worth going ahead for further ablation. And then kept her in, ideally, we should do 30 seconds after bipolar RF ablation. You feel it is near to the coronary artery. I did for 1 minute, and there was a lesion in the circle. Then post RFA ECG, she didn't have any VPC. Then Holter was also done. There was no VPCs. And ejection fraction improved. She's on follow-up for more than a year. After 1 year, again, she developed symptoms. And then again, I took her up for EP study. And this time, before doing EP study, I did the coronary angiogram. And then there was no lesion. So it would be a spasm at that time. And this time, you won't believe, I did aggressive ventral extra stimulation, and all the antiarrhythmics was stopped more than 5 days. Almost, I feel 1 week we have stopped antiarrhythmics, and she was on beta blocker and mexilatin, both were stopped. And then aggressive extra stimulation was done, but no other VPC or VT was induced. Then she's doing well. She's on regular follow-up. And being an intramural VPC, I didn't want to go be more aggressive. And she's doing well with beta blocker. And sometimes when she has symptoms, I keep on mexilatin. Otherwise, she's doing well. So this another patient, 54 years old male, presented with shortness of breath 3-4, and ECG showed outflow tract VPCs and bicuspid aortic wall, severe LV dysfunction, ejection fraction 23%. Holter showed 26.4% VPC burden, 2 to 3 morphologies. So this was VPCs, different morphologies. And then this you can see here, this patient had a small R, and then we did mapping in the left cusp. We didn't get success, went in the coronary sinus, transient success, and then we did a bipolar ablation for this patient. This is a coronary sinus, and then in the left cusp, this is a catheter is there. And this is ideally this was a very good case because the orientation of the ablation catheter and the returning catheter should be perpendicular to each other, and it should be away from the coronary arteries. And this patient had an excellent result. Both the catheters were more than 5 mm from the coronary arteries, and they were in perpendicular orientation. There was complete suppression. This case was done in 2018. Almost 7 years post-procedure. He is doing well and totally asymptomatic, and he has mild LV dysfunction post-procedure. Even till this day, his ejection fraction is 48% and totally asymptomatic. So concluding, coronary venous angiogram is very useful in delineating coronary sinus pouches, and you can know the likely cause of supraventricular tachycardia. If it is wide CSOs, it's more in favor of a AVNRT. If it's a tubular, more in favor of a AVRT. Coronary sinus mapping should be considered when assessing LA origin tachyarrhythmias because you have connections from both LA and RA. Ablation in CS is useful in select cases of atrial fibrillation, atrial tachycardia, AVNRT, AVRT, and ventricular arrhythmias. Intra-procedural CAG is must to ensure safe ablation when we are doing ablation within the coronary sinus. One more thing I would like to say, I suggest to do the CS angiogram for every patient of SVT, and even prior to going for cannulation of a CS in lieu phase if patient has a arterial sheath. Because sometimes we think a patient has palpitations because of health, only because of sometimes it could be possible that around 2 to 4% of the SVT patients can have a coronary artery disease. And in fact, if we can know a coronary artery disease earlier, then we can treat that and do the arrhythmia management later. So, as electrophysiologists, when we see arrhythmia, when we are not getting success, one thing which we must keep in our mind is coronary sinus arrthymogenic potentials, and radio frequency ablation at that juncture place will be successful, as Sri Rama got victory over Ravana on this day of Diwali. Thank you very much, and welcome all the electrophysiology postgraduate DM to attend the Indian Heart Rhythm Society National Conference at Visakhapatnam, 31st October to November 2nd. Thank you.
Suresh, am I audible?
Yes, sir, you're audible, sir.
Suresh, I was a little late to join actually, but a fantastic talk, and I just want to ask you that when you want to measure the distance from the coronary vessel and your ablation catheter tip, how reliable you can be. It's very difficult to say 5 millimeters, 6 millimeters, or 4 millimeters.
Yes.
So how do you kind of really measure these distances?
So that is based on the reference of the catheter, coronary angiographic catheter, sir. The rough estimate of what we get if you use a say 5 French or 6 French catheter based on the 0.33 into 6 2 mm, based on the visual estimate by the UCM method, we can have how much is the distance between the coronary the ablation catheter and the coronary arteries, sir.
So how do you decide that you want to give bipolar ablation versus going to the epicardial route? For example, you don't get in the coronary sinus. You are epicardial, but the focus may be a little away from the coronary sinus.
Yes,
so
sir.
in that case, you may have to go to the epicardial. How do you decide?
Sir, first thing is by doing a 3D mapping, you can unipolar map you can see, sir. If you have unipolar substrate you have endocardial normal substrate and unipolar substrate is showing scar, it suggests epicardial. So in that case, there's no point. Most of the ARVC case, they have epicardial substrate. Endocardial may be a very good voltage, or then those substrate of the patient directly epicardial you have to go. But these are the case of idiopathic ventricular arrhythmias, and I do all my cases. I do cardiac MRI. At least I have a substrate of the heart. So if there's no much epicardial scar, then I try to go within the coronary sinus. And when we do mapping at the cusp or at the RVOT, then we can know the earlier signals will not be very much, it will not be like 30-40 milliseconds, maybe less than 20 milliseconds, and wide area of activation. And these are focal, centrifugal activation pattern should be there. So it should be pointed activation should we expect. But when there's no pointed activation, it is a wide area of distribution, and the earlier signals are only 10 to 20 milliseconds, then we think these could be intramural origin. And in the similar thing you get at the both ends of the surface, like if the left cusp also shows 20 milliseconds earlier from the QRS, and even CS also shows 10 to 20 milliseconds from the QRS, then it is highly likely that it is an intramural origin. And this is one point. Second thing is wide area of activation in the 3D mapping. So these are the two things with which I can know then this subset, and it doesn't go with ablation at one place. It goes and recurs back after 10 to 15 minutes. So these are the three things which I see, and then I go for bipolar ablation, sir.
Right. On an average, roughly, how many patients you have to go bipolar in a year? Any idea?
Sir, around 5 to 7, sir. I suppose in a year, easily 5 to 7.
That's a good number, actually.
I have to publish that, sir. Being a bit lazy, I think after this talk, I think I should write up.
You should. I think it's very interesting because we have to go bipolar very, very rarely. We may be missing actually some of those few intramyocardial lesion, focus VPC. But it's very interesting that your incidence of going bipolar is at least 5-6 cases per day. I think you should publish. Very interesting.
That is in last 2 years only. Suddenly it has increased, sir. Like otherwise, previously I used to be very less, but now in last 1 year I have seen 5-6 it has been occurred. In previous like 7-8 years I didn't have that much, but maybe as we see more complex cases, it is coming up like this way, sir.
Very good. I think it's a good idea to actually, I've been always saying that we should have registry for ablation in our country, but so far we have not succeeded. I will try to push in the IHRS meeting this year. It's a great learning from each other that you have bipolar, you have VPC ablation and ventricular tachycardia ablation. And okay, you do learn also the common Gardner, AV, and RT difficult cases. So some kind of registry will be very useful to have in India. Let's hope that we talk to the EP leaders this time. Hopefully, we get it up. So, are there any? Anyway, good luck. Happy Diwali to all of you, Suresh, and good luck meeting. I'm sure you are working very hard, and it should be a very interesting and useful scientific meeting. If there are questions from the audience and the chat box, you see that. If there are any questions, you can answer them. Do you have any questions on the? I don't see any.
Nothing is there. No questions are there.
So I think if there are no questions, we thank you profusely and also request you to come on this dais again and again,
Definitely,
so that our fellows can have a advantage of your experience. Thank you.
Thank you very much, sir. Good day, sir.
So I think we can leave the webinar. The national board people, anything they want to say?
Yes, sure, we can conclude, sir.
Okay, thank you very much.
Thank you, sir.
Thank you all. Thank you all.